important part of your history. When you have over 6 hours of ischemic type changes to a limb, okay, you worry about irreversible damage. So vascular injuries are increased with, with the proximity to bones when you have fractures, okay? The supracondylar fracture, okay, is kind of a big deal, especially in children, okay? You worry about brachial artery injuries, okay? Posterior knee dislocation, posterior knee fractures, you worry about popliteal vessels. So when you think about vascular injury, sometimes it occurs on where the proximity of the injury is, okay? Arterial injuries associated with fractures, so clavicle fractures, okay? 90% of clavicle fractures are no big deal, okay, are non-operative, only 10% get surgery. But sometimes, you can have, so we talk about proximity, so sometimes you can have a really angulated, awful disrupted clavicle fracture, you worry about subclavian injury, shoulder dislocation, worry about axillary, supracondylar, we're talking about brachial, elbow dislocation, worry about brachial vessels, pelvic fractures, worry about gluteal and iliac arteries, femoral shaft femoral, okay, knee dislocation, popliteal, and then tibial shaft tibial. So, kind of worry your fractures, you kind of need to know your anatomy. You need to know what's in this area, okay? So what is this? What is that? Okay, that's a projectile, that's a bullet. So this guy has a fracture secondary to a gunshot wound, okay? So the incidence of fracture dislocation with vascular injury is uncommon. 3% of long bone fractures. Obviously increases in incidence with GSWs means gunshot wounds, okay, up to 38%. Then posterior knee dislocation, 16 to 40%. Mechanism of injury important. When we talk about trauma, okay, penetrating traumas, impalement, stab wounds, gunshot wounds, blunt traumas or falls, car accidents, hit with a bat, blunt trauma, okay? Blunt trauma, 27% amputation rate versus 9% for penetrating trauma. So types of vascular injury, y'all remember going through the anatomy, the intima, some neural stuff, okay? So you can get vascular spasms, okay? So you get people that have vascular spasms, you can get some ischemic type changes, intimal flat tears, some intimal hematomas, lacerations, okay? Thrombosis and occlusions, AV fistula. I had a recent PA friend of mine that she was in the hospital for a bunch of other issues, and she had some ischemic changes, and she actually clotted off her entire leg, okay? She ended up having to get a dissection of her fasciotomy, dissection, and has a lot of problems. Has a permanent foot drop, secondary to it. She actually had an arterial occlusion of the right lower extremity. So consequences of vascular injury, obviously blood loss, ischemia, compartment syndrome, tissue necrosis, amputation, and death. Vascular injuries are a big deal, okay? In trauma, we talk about the multiple severely trauma-injured patient, we talk about the golden hour. Vascular injuries are kind of the same way. It's a very, very time-sensitive issue, okay? Why is it a time-sensitive issue? Because people can lose their limbs, okay? It's a big deal, okay? What do you think happened to this guy? It's a motorcycle accident. You're correct. So prognostic factors, what determines how well these patients are going to do depends on the level and the type of vascular injury. Thank you, sir. Do they have collateral circulation? You got to know your anatomy, okay? Sometimes, as a matter of fact, you get people that have little arterial lacerations and lacerations in their hands, and these little arterial bleeders, you get pressure, lacerations. So you got to know your anatomy. You have collateral flow, okay? How do you assess vascular on a neurological on a physical exam? How do you assess vascular status or vascular status? Cap refill should be less than what? 2-3 seconds. Okay. What else? Pulses, right? Okay. When you talk about the color of the skin, okay, you say is it pale? Okay. Is it dark? Is it blue? Is it black? Is it dusky? Is there pallor? Okay. And you talk about the temperature of the skin. Okay. Those are all things that you should have when you're assessing the neurovascular status of the affected extremity. Okay. So when people are bleeding out, okay, when they're in shock and they're hypotensive, they can increase ischemia. Okay. Less blood flow to deal with. Tissue damage, crush injuries. Crush injuries are big important things to talk about. Okay. When you have a crush injury, in addition to having soft tissue damage, what is a big thing that you worry about developing as a result of a crush injury, a big complication of crush injury?
Compartment syndrome.
Compartment syndrome, rhabdo, okay, rhabdomyolysis, okay. And obviously, you have a patient that comes in that has extremity trauma and he has peripheral vascular disease, he's got a FIM-POP bypass, okay. So there's some other conditions that may kind of red flag and warrant some other things that may develop down the road. But patients, other comorbidities happen, okay. What do you think happened to this guy? In the end, what do you think happened to his leg? He lost his leg, okay? This happens all the time. These patients come to the trauma center and their arms are mangled and pretty devastating. This is a devastating injury for the rest of this individual's life. Okay. So, what happened to this patient here? What's going on with this guy? He shows up, and what did they try to do here? What's going on in that picture? They're trying to splint him. Okay. So this guy had an obvious fracture, and this is all blood and bleeding here. Okay. So when you have, you want to try to splint the individual and obtain control for bleeding. Okay. So how do we diagnose these vascular type injuries? Obviously, physical exam we talked about. Ultrasound, arteriogram, okay? The big thing these days, arteriograms, you got to have obviously you have to have interventional radiology, okay? And to be able to do an arteriogram. Kind of the gold standard these days is really CT angio. These CT scanners and the amount of slices they can get, a lot of these slices are 64 slice scanners. So CT angios are really helpful. If you need arteriogram, get arteriogram. CT angios are very good. Do y'all know, have y'all ever heard of the term an ABI? Okay, have y'all done it? Do you know the difference in taking someone's blood pressure? Yeah. When you take someone's blood pressure, you pump up the blood pressure cuff, and you let it off. What you're hearing is an opening pressure, okay? And I'll get into it later. When you do ABIs, you're using a Doppler to listen, and then you're looking for a closing pressure, okay? So a little different. I have some slides I'm going to show you in a little bit, okay? But how you vasculate is a Doppler, doing ABIs, ultrasounds, arteriograms, and exploration. Okay? Just because someone has pulses, does it mean they do not have an arterial injury? Does not. Absolutely. People can have pulses and still have arterial injury. Okay? Physical exam. Okay? How much bleeding to have? Is it major? The hypertensive, really shocky? What is one of the things you see, the difference in a venous pulsation? If you have a laceration, you got blood shooting out, what is one of the difference you see between arterial and venous?
5% arterial.
Arterial is kind of pulsing and sometimes shooting out. Okay? Venous is sometimes kind of a little slow leak, and arterial is a little brighter. I had a guy a couple weeks ago, his daughter, he started off the day, it was a bad day. She ran into the car, into the garage door of the van. So he's out there working on the garage door, doesn't know it, and I don't know if you've ever been on garage door springs. They're very big and they're wound tight. He loosened up, the garage door exploded. Lucky he didn't lose his eye, but laceration from here all the way up to his scalp, had huge arterial bleeding just kind of pumping out. But arterial bleeds are pretty easy to see sometimes. Okay? Obviously in physical exam, expanded hematoma is something you worry about. You see people with huge, big swollen, we talked about your pelvis, you can lose a lot of blood in your pelvis, but in your thigh, you can lose a couple liters of blood in your thigh easily. Okay? All those are distal pulses, pallor, temperature differences, these are the kind of things we talked about. Asymmetric pulses, okay, warrant an ultrasound. ABIs we talked about. Absent pulses warrant emergent vascular consultation, surgical aspiration. It's amazing sometimes when you guys you get out and practice. I reviewed some trauma CQI cases. We had this guy, it was a car accident out in the middle of nowhere. He was ejected, and when they came up on the scene, he should have been a scene flight. He had no documented pulse, okay, to his right lower extremity. He went to the small town ER. They scanned him for 3 hours, okay? Scanned from head to toe, delaying care. If you don't have to care this patient, you need to get him out. So problem number one is should have been a scene flight. Problem number two, they should have scanned from head to toe. This guy flew from a helicopter, he coded 5 minutes out, okay, from Mobile Medical Center and died, okay? So vascular, since this guy has no pulse, he needs to be somewhere and get a vascular surgeon, okay? So vascular injuries can be a big deal. And obviously, he had a bunch of other traumatic injuries, but time is of the essence. And the whole purpose of our trauma system, to have a trauma system, is to try to get the patients to the right place and the right time, and have the right ability to care for patients, okay? So here's an ankle brachial index we talked about, okay? Believe it or not, it's kind of tough to find a manual blood pressure cuff in hospitals these days, because everybody has these electronic computerized things. So what you need is a blood pressure cuff and a Doppler. This is an ultrasound with a speaker. It's a Doppler ultrasound, okay? So you put that little pin, okay, on the extremity and you hear the pulse, okay? So when we do an ankle to brachial index, what we'll do is we'll put the blood pressure cuff on the arm, we'll put the Doppler here, and we'll hear the pulse. We pump up the blood pressure machine until we can't hear the pulse. That's the occlusion pressure, okay? And you do the same for the dorsal pedis, the same for the posterior tibialis. and it's the inverse ratio, okay, of your ankle to brachial. So a 1-to-1 ratio, you don't have a vascular injury. 0.9, 0.9 and less. 0.9 is kind of equivocal. Anything less than 0.9, you're concerned about having a vascular injury and you need to get further imaging, whether it's an arteriogram or CT angiogram. Okay? You show up on your ER rotation and you have some guy that gets a gunshot wound to the leg or a stab wound to the leg. Okay? You say, hey, let's do ABIs on this patient. They're going to think you're going to look like a rock star. Okay? But again, knowing anatomy. If I have a stab wound to the lateral thigh, am I worried much about a vascular injury? No. If I have a stab wound to the medial thigh, am I worried much about a vascular injury? Yes. Gunshot wound behind the leg, am I worried about it? Okay? So, know your anatomy. Okay? Because that's what you're taught. You got to know your anatomy, know your patients. Okay? Next thing, projectiles. Okay? Bullets, they travel. Do you think they go when do you think they go from point A to point B with an entrance and an exit, or sometimes you have entrance? You think it just hangs out in there? Lower velocity, lower caliber guns, lower caliber projectiles like a 22, they're much higher velocity and they rotate and they tumble. Okay, so when they get in there, they cause a lot of damage. Okay, anytime you have a penetrating trauma, a gunshot wound, okay, you want to always document is there an entrance or an exit wound. Okay. One of the things that's often helpful, they have these little markers, looks like a little arrow that you can put on the skin, looks like a clear band-aid with a little marker on the HIC x-rays, you can see where an entrance and an exit wound is. A night trauma team one night took care of this guy, looked like a simple entrance exit wound to his gunshot wound to his leg. They admitted him for neurovascular status, just kind of watch him overnight. And we have a trauma panel at your lab, the CBC, CNP, amylase, lipase, when they hit the door, kind of just routine labs are drawn. So people got focused. It's so easy to get focused when you have this injury. They were focused on his leg and didn't look at anything else. So it happened tonight. I come on at 6 o'clock in the morning, the nurse says, Brad, I'm worried about this guy. He's really struggling. He's short of breath. They call the resident. Oh, he had too many narcotics. He's just, not breathing. So I go up. This guy has a very rigid abdomen. You can look at his labs when he came in. He had an amylase of 2,000, okay, when he came in. You get a chest x-ray and he's got a bullet sitting by his pancreas, okay? Had someone paid attention to the labs, the trauma panel that you drew, they didn't notice this guy had another bullet. He had an entrance and exit with essentially the same wound. Okay? So you can't get focused. Just because these people come in with that foot and that leg is hanging off, like, oh, it's so terrible. You worry about his leg. You got to totally evaluate the patient. Don't hone or focus in on the obvious injuries that patients have, because sometimes they have other injuries. Okay? Sometimes these patients come in, they're high on PCP, cocaine, crack, alcohol, and lots of times on your tertiary survey the following day, you find injuries that the patient didn't know they had because they're focused on their leg pain, etc. Okay? So we talked about the ankle brachial index. Again, you guys can kind of crease through and read this, okay? We talked about the ABI. The numerator is the ankle pressure, okay? So the ankle pressure over the brachial for the DP and the posterior tibialis. So pretty much you think of 1 to 1 is the normal ratio. 0.91 to 0.99 is equivocal. Then you worry about mild and moderate peripheral vascular disease or an abnormality. So anything less than 0.9 needs further evaluation. And this is a picture of them obtaining Doppler. Sometimes, depending on the quality of your Doppler, sometimes they're very hard to hear, especially in a loud, you're in a loud trauma bay, with everybody talking, you get everybody to be quiet because it's hard to hear the pulses. Again, correctness of a signal that they have pulse that you can hear doesn't include they have an arterial injury. So non-invasive scanning, okay, ultrasounds, okay. You have a sonographer come and they can do an arterial and a venous, okay, and a venous evaluation. Totally different studies, okay. So you have to delineate when you tell the sonographer what you want to evaluate for. Are you worried about a venous injury? Somebody comes with a DVT. What's a DVT? Deep venous thrombosis. So it's venous. Okay, it's a venous study. Okay, so when you worry about arterial, you're worried about pulses, color, okay, capillary fill, those kind of things. So you delineate whether you want an arterial. Sometimes you want arterial and venous studies. Okay, but when you're worried about arterial injury, it's an arterial study. Angiography. You'll see the veins light up, or see the arteries lit up back here with contrast. Okay. So this has a distal femur fracture. We're worried about a popliteal vessel injury, so they're doing arteriogram. Okay? And lots of times they do is intraoperatively too. They do our intraarteriogram as opposed to going to the cath lab before they go ahead and take the surgery. Okay? Here's an arteriogram of the pelvis. sometimes people will get, when you guys are out in practice and you see a CT report that comes back and says active extravasation or a blush, okay? Those terms should be a red flag. Ding, 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 okay? That means an arterial bleed, okay? So if you see in the CT report active extravasation, IV, contrast blush, that means that these people have an arterial injury. So based on where it is and what it's doing, sometimes interventionalists can go in and coil, kind of cauterize the bleeding, or versus obviously intraoperative fixation depends on the injury and other things that are going on. Angiography is expensive, okay? Also, you worry about dye load, okay? So IV contrast can hurt your kidneys, okay? So you have a trauma patient that comes in and they get a big contrast CT of their chest, abdomen, pelvis, and you turn around and have to give them an angiography. Now, obviously, when you talk about loss of life or limb, you have to do the study, but the arteriogram is something you have to take into consideration. It's more IV dye. And some people also have anaphylaxis to IV contrast. So let's talk about CT angiography. It's alternative to arteriogram. And then the last, gosh, when I started, I think at OU in 2001, they had an 8-slide CT scanner. So it means it can take an 8 image picture, okay? And so now, they have 120 slide CT scans. Technology is really, really good. So the quality of the studies are much improved and better, okay? And then then another thing is, if you have a trauma patient comes in, you're going to get a CT scan. A CT angio is nearly as good. It doesn't delay by having to call in a team to do an arteriogram. And here's an operative angiography. Surgical aspiration, okay, is one of the things sometimes you have to do. Somebody has an arterial injury, they have no Doppler signal side of the injury. This kind of talks about what happens if you have a patient, okay? There's no pulses, there's an obvious injury, surgery, okay? Multi-level injury, you can do an arteriogram, ultrasound, CT angio, and it talks about asymmetric pulses, okay? Then you kind of start with an ABI and you determine from there. With a normal exam and normal ABIs, you can observe those patients. Like any trauma patient or issues, is you have repeat observation, repeat examinations, okay? Lots of times you have people that you suspect having vascular injury, you admit these patients, observe them, you may be neurovascular exams, get to the nurses, sometimes they say Q1 hour times 4, Q2 4 hours. The nurses don't like it, when you put them on the floor and you're doing a ton of neurovascular injuries, they have lots of patients, but reassessment and repeat assessment, just because the initial neurovascular exam is normal doesn't mean the next one will be. So when you have heightened security and injury and suspicion, you need a repeat exam for these people. How do you evaluate for compartment syndrome? Okay. Exactly. Okay. So Stryker needle. Stryker is the company that brings the needle to check for compartment pressure. It's one of the things you can also, if you don't have a Stryker needle, you can use an art line set up from the ICU and an IV cath and put it in the compartments to check pressure. It's just a little more labor intensive. So when you have trauma patients, you have to go to surgery, who goes first? You have a vascular injury. Obviously losing the extremity is important. When people have multiple injury, you have to determine what needs to be addressed first. And if you're worried about vascular injury, obviously it's one of the first. Sometimes we'll do temporary shunts. We'll do fracture stabilizations with an external fixator to kind of, just enough to get them stabilized. A lot of times when you stabilize the fracture and the affected extremities, that will help with blood flow. Okay, so sometimes you kind of do a temporary stabilization intraoperatively and go back and do a fixation, whether it's an intermedural rotator nail or some other pin. So sometimes we'll do through that. The next thing to worry about, sometimes these people have these vascular injuries, and you got a guy that gets his leg in an auger, and it looks like it's unsalvageable. Sometimes it's a struggle. It's a struggle with some of these surgeons and families to determine, are you going to try to salvage this extremity? Okay, is it salvageable? Lots of times, they'll try, but people end up getting infection and surgery after surgery, and then, you can get septic, okay, and develop other complications. So sometimes you got to make the decision, this injury, is it salvageable, or does it need amputation, as definitive care? Fasciotomies. What's a fasciotomy? Why do you do a fasciotomy? Carpal syndrome. That's right. So we talked about, what goes first, talk to the vascular doctor, temporary shunts, fracture stabilization, salvage versus amputation, fasciotomies. Okay? So every orthopedic injury, okay, is a chance of having vascular injuries. And obviously, anytime you have a patient, something as simple as, just as simple you think is a simple fracture, all you want to give these patients precautions, neurovascular precautions. Okay? Teach patients, teach families how to test for capillary refill. Okay? You put a splint on, last thing you do is put a splint where you got pulses, and you can reach your hand up in there. Make it easy, make it accessible for patients, if you're sending people home to check their neurovascular status. Okay? Teach them and show them. Okay? It's very important. So, vascular injuries, the most common vascular injuries that occur because of fractures, okay, are supracondylar fractures, knee dislocation fractures, okay, when we're talking about fractures, okay. Those are the most common vascular injuries that we see that occur. Now, they can occur everywhere. Time is crucial. You gotta have a high index of suspicion, okay? And we're gonna get into compartment syndrome again here in just a minute, okay? How do I find it on here?
If you exit out of that one, it should be the one. If you click back on the room.
There we go.
We only had two, is that right?
Yeah, I have another one up here. I can put it in just a minute.
Okay.
And I wish I'd have done this one kind of first, but that's okay.
One more over. It's the one that was a big screen. One more.
Perfect. All right, so who here knows about trauma and the trauma system we have? Anybody have any idea how trauma works? So we're going to talk a little bit about trauma. Trauma is the #1 cause of death for Americans between the age of 1 and 46. It's the #3 cause of death behind cancer and heart disease. Okay? Each year, trauma accounts for 41 million ER visits and 2 million in hospital admissions. And accounts for over 30% of all life years lost. Economic burden of trauma is more than $671 billion annually. Okay? 192,000 people lose their lives to trauma. Here's kind of some more, kind of expanding on that. We talk about the cause of death. It's the #1 for age group 1 through 46, or 47% of all deaths in this age range. And if it's the #3 is leading cause over all age groups. Burns. Okay? 450,000 burn injuries require medical attention annually. 40,000 hospitalizations related to burn injury. And then falls. Okay? Geriatric population. Okay? We have a ton of falls every day. Okay? These old people, elderly population, that are on blood thinners, that are falling, that fall and hit their head and have hip and pelvic fractures on blood thinners. And that's pretty awful. So we have in Oklahoma called the TREC, the Trauma Referral Line. Okay? It's a line that can be called when we have trauma patients. These lines are called by hospitals, they're called by EMS. When you work at a trauma center, you walk in the room, there'll be 5 or 6 or 7 or 8 people standing over you when you hit the door. Okay? At OU, the Department of General Surgery is who makes up our trauma team. Okay? When a patient is labeled as a trauma patient and comes to the emergency department, there's a page that goes out, that comes out. So what happens is the trauma team assumes the care of this patient in the emergency department. Some ER docs in the ED will come in, some will assume the airway, some are very active in their care, some are not very active in the care. The patient needs to be admitted to the hospital. They are admitted by the trauma service and taken care of from admit to discharge. Okay? So lots of times you come to a big trauma bay, it's kind of overwhelming, all the people, okay? People are cutting off clothes, examining patients, etc. You're working in a small town ER, you're a nurse, okay, depending on the facility you're at. The University or the state of Oklahoma has one level 1 trauma center that's designated by the American College of Surgeons. That's OU Medical Center. The difference between a level 1 and a level 2 trauma center is essentially a lot of academia and research. Okay, St. Francis and St. John's in Tulsa act as a level 1 trauma center, and they alternate days, odd and even days in Tulsa. So how do patients get to the trauma center? Air ambulance, okay, ground EMS, private car. This is my wife taking the picture on my motorcycle one day in class, and it's like, you got to take a picture. Okay?
Oh my
People get to the ER by private car. Okay? They dump their buddies out on the driveway. He got shot down the road. We really care about him, so we left him in the driveway. They gotta bring him in. Okay? People come in like people from Thriller video. They hobble into the ER. Okay? Our trauma system, you know, we were really didn't have a trauma system until Dr. Albrecht came here. He came here in 2000. There was we talked about the golden hour. Is a time-sensitive hour, the golden hour for people who have acute, severely injured trauma patients. You have an hour to get them where they need to be to help save their life. There was a trauma patient that had a bad outcome and died, coming from Shawnee. There was a big deal, Dateline, kind of this big story, and that kind of got our trauma system getting started. And Dr. Albrecht, you know, with the help of Dr. Tuggle and the rest of the university campus in the state of Oklahoma, helped start our trauma center as a result of that. Okay? So it's a coordinated system to care for injured patients, get them to the appropriate facility, the appropriate resources to try to decrease morbidity and mortality of these trauma-injured patients. So we talked about the difference, okay, a level 1 and a level 2, okay? Again, the level 2 is still a level 1 without the teaching and research requirements, okay? So the big metro hospitals around the area, Baptist, Southwest Medical Center, St. Anthony's, Deaconess, Midwest City, those are all kind of level 2 facilities. A lot of private little small town surgical hospitals, small hospitals are level 4 facilities. This is a map, trauma regions by hospitals and trauma level. We're region 8, okay? So based on where you're at, it's kind of where your tertiary trauma centers are. Obviously, OU Medical Center is here in region 8, Tulsa's up here. So, you know, lots of trauma down south will go to Dallas, okay? Some in southeast Oklahoma will go to Sherman, Denison. You know, some of the stuff goes to Arkansas, some of the stuff up at Region 2 goes to Wichita, and Region 1 goes to Amarillo. So depending on where you're at, where the biggest level 1 trauma center is kind of depends. Region 8 and Region 6 are pretty close. So Region 6 is Norman. Norman sends a lot of trauma to OU. This kind of shows EMS stations dispersed around the state, as well as helicopter locations and bases and fixed wing helicopter stuff.
Brad, did you say that Tulsa has a level 1?
They function as a level 1, yes, sir. They do. They're just not certified by the American College of Surgeons. They didn't go through the accreditation. So St. John's and St. Francis act as a level 1 trauma facility. I mean, and the great thing about Tulsa is they are so good at what they do. They you know, odd and even days. All the paramedics, everybody in the area knows if it's an odd day, you're going here. If it's an even day, you're going here. The problem we had in the metro is our trauma system kind of fell apart. You know, we have what we call the level 2 rotation call here in the metro. And so on level 2 days, so traumas that are designated a level 2, not necessarily a obvious life-threatening injury, but the lower acuity stuff, the whole reason for getting the rotation call was to try to de-stress OU Medical Center. They need to be taking care of the life-threatening, big, critical injured patients. And so how you decompress them and give them a little relief is letting some of these less critically injured patients go to some of these level 2 hospitals. So there's a level 2 call. So if it's a level 2 trauma, the level 2 trauma patients would go to the area's hospitals on call that day in the metro to try to decompress OU a little bit, let them take care of the more critically injured patients. Unfortunately, you know, we have a lot of trauma transfers. You know, most of the transfers, believe it or not, are typically things that general surgery and orthopedics can take care of. Every level 4 trauma center is required to have general surgery and orthopedics. But lots of times, there's some other specialties that they don't have, whether it's facial surgery, you know, EMT, like or maxillofacial surgery, or plastics, or hand call. Sometimes neurosurgery is kind of an issue. But we have you get a lot of transfers from these other level 2 facilities that should be able to take care of stuff. We're like, oh, let's just send it to OU. We don't want it. And so, in the last 10 years, we're trying to get these hospitals, level 2 hospitals, to list. You have every opportunity to take care of these patients, and trying to get in the mentality of transfer to OU, transfer to OU. Let's take care. If you have the facility and the capability, okay, we call it capacity to take care of it, you need to take to it. If you transfer a patient, you have the capacity to take care of it, it's a convenient EMTALA violation. $50,000 fine for the provider, $50,000 fine for the hospital. That's an EMTALA violation.
Is it getting better?
It is. We've had some changes. This last year, and I'll get to a little thing here in a minute. This last year, what we changed was, let's say, for example, let's say you're a trauma patient in Midwest City, or Hera. Say you're a level 2 trauma patient, and that day, Mercy is a level 2 facility on call. you're going to pass 5 hospitals that have the capacity and capability to care for your injury, but you're driving all the way across town. So in November of 17, we made it effective that now we're going to the level 2 facility is going to the closest appropriate, here in the metro, going to the closest appropriate level 2 facility unless it's a neuro, hand, or face. If it's a neuro, hand, or face that day, they go to the level 2 facility on call. We're just trying to make more sense instead of moving patients all the way across town. But as a result of that, some of these hospitals have to step up their coverage and convince their specialists, hey, you've got to take care of this patient if they show up. So our regional plan is to ensure trauma patients are stabilized and transported to the closest appropriate hospital facilities, available resources and capacity to provide definitive care. Okay? So we have these triage and transport guidelines, and we're trying to match, resources that they have. And so this has been a big ordeal in the taking. You don't think about how big this trauma is, but when you have a family member or friends affected, it's come something I'm really passionate about. I really care about trauma. I really care about trying to improve and help the system. This is what our regional 2. This is the last one. This last year, what it looks like. So this is who's on call for the level 2 facilities. This goes out to all the hospitals, the EDs, and ED managers. They know who's on. So different days. Now sometimes they'll use on level 1 and 2. Sometimes they're taking level 1 call and level 2. They're on the same day. Just kind of alternates.
Brad, who manages that schedule?
Jana Timberlake at the Oklahoma County Medical Society. The Trauma Rotation Call Committee, which I'm on, it kind of got started when, with Dr. Sacra and Dr. Cannon and y'all, Roxy and the hand guys. It's a subcommittee of the RTAB that really it's a committee with a bunch of physicians that actually gets stuff done, even though it's a subcommittee of the Regional Trauma Advisory Board. But it's made up of physicians, and so that's who manages that. The trauma coordinator at OU and Jana really kind of work on, and the ED managers are kind of getting this call. There's a lot of swapping sometimes of days, but it's kind of things that have to go through Jana.
So it's a professional society, not the government.
Correct. Yes, sir. Yes, sir. That is correct. So this is St. Francis. They're on even days. St. John's on odd days. These are things that you can look and read. I'll go through these, but these are trauma patient triage definitions and guidelines to help to assess if a patient's a level 1 or a level 2. And again, you use priority 1 and priority 2, and levels are kind of synonymous, the terms we use together. Determine what patients are. Okay. Mechanism was a big thing that has been used forever. A rollover accident, was kind of used. Well, they're a level 2 because it's a mechanism. Mechanism is it's important, but it's kind of gotten thrown out a lot. We have to take a lot of consideration in pregnant patients and the geriatric patients. Over the last 10 to 12 years, the amount of patients that are on blood thinners or on Plavix, okay, and these blood thinners has really, really increased. Okay, Coumadin is one of the older blood thinners a patient used to be on. It's a pain in the butt for patients because foods you eat and other medications can affect its efficacy, and you have to take pills and you have to monitor it. And so some of these newer medications, they don't have to be monitored. So the physicians like it, they don't have to bring patients back to check their coags and stuff. So a lot of people on Plavix and some of these newer 10A inhibitors, okay, for blood clots, okay, Xarelto, Pradaxa, okay. These are our guidelines to help you to kind of determine what a priority patient 1 patient is versus a priority 2. They're on the state's websites, okay, for trauma. These are things, again, you guys can read. I'm going to read it to you, but these kind of help to assess pediatric and adult patients, kind of put them in classify, is this a trauma patient, okay? Obviously, gunshot wounds, okay, stab wounds, those are trauma patients. High mechanism injuries and falls, those are trauma patients. Sometimes there's some things that are really kind of hard to tell you, but there are these little guidelines you can look at to kind of determine. EDs you have in the emergency department. If you're not sure, the state gave these book about essentially have these guidelines you can help evaluate. They also have the TREC referral line. You always have available trauma surgeon if you think, hey, this patient needs to be to the trauma center or not. Sometimes they can kind of help you out with that. Helicopter, emergency medical transport, this is something, it's been great for patients and getting patients appropriately to the facility quicker. We have more fixed wing and helicopters per capita in our state than most anybody else. In the last 5 years, we've had multiple accidents. The unfortunate thing is air transport is really overutilized and used oftentimes is not necessary. Okay, and so putting someone in a helicopter and putting the flight crew and patients at risk when they don't need to be flying. We have people with a gunshot wound in the foot that have neural neurological exam and they put them on a helicopter and fly them, it's $50,000. It's $50,000 for a flight. Imagine strapping some company that doesn't have, some family that doesn't have money, $50,000 for an injury that didn't need to be flown. Okay? There's lots of studies that show inside a 60 square mile area that you can get to a hospital via ground ambulance just as fast as a helicopter, with the exception of if there's extrication. Okay? If you have a big car wreck and it's mangled and it's going to take hours to get them out, that's kind of appropriate time for helicopter transport. Okay? One of the things that I actually kind of got help taken care of this last year, I was kind of passionate about, all the helicopters have GPS availability in their helicopters, and they wouldn't share their location. And it was kind of one of those things, we have a map, it's called EM Resource, that tells us what hospitals, every hospital is on EM Resource, and tells you their capabilities, whether they have orthopedics, general surgery, cardiology, but also is a map of resources of all the hospitals that I showed you guys. But in other states, they were using the helicopters to see where they're at in real time. Green if they're available for transport, red if they're not. Okay? So what was happening was, I had a trauma CQI case I reviewed. A 15-year-old kid came into a small town ER, gunshot wound in the chest. The small town ER doc, and she had a nurse and a clerk. She intubated the child, he coded, got him back, put him in a chest tube. There was helicopter company A, was 15 miles south. Helicopter company B was 15 miles north. The clerk calls helicopter company and says, yeah, we'll send one. Well, that helicopter was out on a call. They wanted to keep the money in their corporation, in their company. They sent another helicopter from 120 miles away. Okay? So the goal of our trauma system is to get these patients to the appropriate facility using the appropriate resources. And unfortunately, all these helicopter companies, it really wasn't about the patient. It was about trying to keep money in their system. We still have that problem. There's two competing companies right now in Stillwater. If they're out on a call, instead of giving it to the other competing company in Stillwater, they'll send one from the city. So what we wanted to be able to do was to have these companies show where they're at on this map, where they're at, where the facility that needs a helicopter can find the closest available helicopter. And they refused. Unless all the helicopter companies participated, it'd be an unequal advantage. So we actually had it mandated the state EMS rules this last year. They had to do that. So it's kind of a battle for us that we're trying to help. Okay? This is EM Resource. It shows, these are air medical helicopters on the left. This is in Dallas, Fort Worth area, but also it shows hospitals if you change some stuff. Here's where hospitals are, and here's your helicopter you see in green and red. So we now have this functional in Oklahoma City. So, the trauma system is vital. If you've ever had somebody that's gone somewhere that's had been an injured and trauma patients, it's awful. It's awful that we have no funding for brain injured patients in the state. We'd have brain injured patients that got into a bad car accident, and I'm taking round on them every day for 6 months, okay, until they get good enough to do outpatient therapy and go home, okay. So, obviously, the big lacking things we're having now is psychiatric care. I mean, that's nationwide. We saw these school shootings and stuff, okay. But traumatic brain injury patients, okay? These people's lives are changed forever. So be active, be active in your community. Do what you can to kind of help them. Because that's, everybody has to pick an interest, whether it's pediatrics, whether it's family practice, whatever you're going to do, to find a way to make things better, because that's what we want. We want to make our system better for everybody, where our patients and our family members have the best access to care and get the best they can. Any questions about the trauma stuff? Yeah.
Can you give us an example of when you call the trauma referral number, what that's like?
So when you call the trauma referral line, okay, they'll say this trauma referral, you have an emergency, it's a recorded line. You say, hey, I have okay, I'll give you an example. So I had a 42-year-old male who came in by private car. He was in an ATV accident. He's got a right ankle fracture dislocation, and he's got gross hematuria, and he's in shock, okay? So me being at my facility where I'm at, the whole trauma system, we're doing trauma education around the state. We want to try to get these facilities, when these trauma patients present to the outlying areas, we want to try to get that patient to the definitive care immediately, okay? We don't want to waste time scanning these patients. If you don't have the ability to provide definitive care, you don't want to waste time getting CAT scans and images of these patients. You don't have the ability to care for him definitively, okay? Not only that, probably 35 to 40% of CAT scans are repeated when they go to the second facility because, one, the images can't be read on the CD when they bring it, or they're crap images, okay? But not to mention, getting that patient there, okay, is important. So we're trying to get these outlying facilities to not waste time getting this patient to definitive care. So you tell them what you have, and sometimes they'll say, hey, go ahead and get a CAT scan we have before you're there. So the trauma surgeon, look at the trauma surgeon on the phone, they'll kind of help guide you. They tell you what you have. So sometimes they say, you know, hey, I think this is a level 2 facility. This is a level 2 trauma, not a level 1. Let's direct you to the level 2 facility in call today. Okay, then you'll talk to the physician there. So you'll give them a report of what you have. So depending on, you know, if you're not sure of the criteria it makes by using those guidelines, evaluate whether it's a level 1 or a level 2 trauma patient, sometimes it's hard. Sometimes it's a gray area. For the example I was talking about, this guy, he had gross hematuria, so he's peeing frank blood, bright red blood. He had an ankle dislocation. Okay, he's in shock, he's tachycardic and hypotensive. Just by your exam and knowledge, he has a renal laceration until proven otherwise. Okay? He could have a splenic laceration. He could have a level 2, he could have a liver laceration. You don't know what his other injuries are until you do a CAT scan. You know, where I work, I'm 15 minutes from a trauma center. There's no sense in delaying his care if he needs to get there. So lots of times your information is based off of what information you have on your physical exam or limited studies you've done and or their vital signs. So he, you know, this guy, he's at least a level 2 trauma patient. So, but you just have to be, you know, you try to classify him. If you're not sure, classify him. The track and the trauma surgeon can help guide you kind of what you have and where the appropriate facility for him to be is. One of the things that we've done year and a half ago here, you know, right now all trauma patients, until a year and a half ago, all pediatric and adult trauma patients go to the adult tower, go to Presbyterian Tower. After they're evaluated and admitted, pediatric surgery would come over and evaluate, after the adult trauma team saw the patients, they'd evaluate and admit the pediatric patients. About a year and a half ago, in the metro area, level 2 pediatric patients within the metro are now going to Children's ED. They're evaluated there now. And they're trying to make the push to get more, okay? Some of the problems we've kind of been running into with that is, let's say you have a family. You have a family who's in a car accident, and there's a mother and a dad, they're in a car accident, and 2 children. Is separating families has been a little bit of a problem. You know, imagine having 2 kids with no parents at Children's and the 2 parents are at Presby. So it's kind of some logistical, geographical problems that kind of occurred with that, but they're kind of trying to work through some of that. Right now, you know, burns, things that we have kind of affecting trauma in this area is burns. Baptist is really the only burn center we have here in the metro. About a year ago, they put a big press release that they're taking pediatric burns now. And so we're actually trying to work on getting a state plan developed with Dr. Lentz, the burn director at Baptist, to come up with a plan. The problem is himself, there's 4 burn surgeons there, 2 of them will do peds burns. One of those have been on maternity leave for the last 6 months or so, but the other 2 don't. So we're trying to come up, depending on the day, you know, that would be the problem with burn patients here in the metro. If you're a trauma patient with a burn, they don't want you. You know, they don't do, you know, they're not comfortable taking care of a severely traumatic injured patient that has a burn. You get a guy with a motorcycle wreck that, you know, that piles into the back of a car and the motorcycle exploded, and he's got, you know, 40% burns over his body, and he's got spine fractures and splenic injuries. They don't want them. So we send burn patients to Wichita, to Dallas, all the time. And you know, and that's what kind of stinks too is, you know, depending on the attending on, yeah, they may take a pediatric burn patient on Tuesday and Wednesday when one attending's on, and the next day they won't. So I've actually talked to Dr. Letton today about, we've been trying to get the burn people to meet with and trying to come up with a state plan to really kind of define what our burn protocol is going to be for burn injured patients in the city. So those are kind of big things in trauma right now in the metro. We're trying to come up with the burn stuff. Then obviously Stop the Bleed is huge right now with all the shootings. I'm doing tactical combat casualty care with OHP, and we're teaching, and that's what Stop the Bleed is tourniquet care, okay? The amount of lives that have been saved in the world wars due to exsanguinating hemorrhage from extremities, you would not believe some of the wounds these people have, that they get IED explosions in their extremities and ankles. So tourniquets are huge in care now. Tranexamic acid is a big thing that's used in trauma for people that are bleeding. We have a protocol in the metro. So a lot of times these trauma patients, when they start bleeding, they become coagulopathic, okay? And their clotting factors essentially are just diluted. And these people get hypothermic and they bleed out. So TXA is a protocol we have to help reverse bleeding issues. And paramedics, they have a mechanism of trauma with meet criteria for hypotension and shock. The paramedics will give a gram of TXA en route, and we'll give another gram here at the trauma center. But you know, a lot of these things we're doing, the tourniquets and the TXA, these are things that have been studied and done in the military for 10 years. We're always kind of lacking behind. It's kind of funny, some of the resistance we've had in emergency medicine and hospitals to use a tourniquet. You know, some of the simple tourniquets stop arterial bleeding. So. Howard, where can I put this to put in the compartments in there?
I guess understand that one more thing.
Y'all want to take a break before we do this next one?
Yeah.
Why don't y'all take a break real quick?
Here, let me train you.
I never got anything.